All right, we will go ahead and get started. I'd like to welcome everyone to the sixth in our series of 10 webinars that the Oregon Office of Rural Health is hosting, focused on critical access hospital finance and operations. Today's webinar is 10 CAH revenue cycle priorities, what to review immediately. I'm Sarah Anderson, the Director of Field Services at the Oregon Office of Rural Health. Next slide, please. Before we get started, I'll go over a few logistics. So first, the audio has been muted and the video is turned off for all attendees. You can select the ellipses on the right of your screen to populate the chat feature. And please use this chat feature to ask your questions anytime throughout the presentation, and we'll monitor the chat for questions and ask them of our presenter at the end of the webinar. You can also raise your hand by clicking on the hand button on the bottom of the screen, and then we can unmute you and you can ask your question live. The presentation slides and recordings will be posted shortly after the session on ORH's website at the link I will put in the chat in just a moment. Next slide, please. And as I mentioned a moment ago, this is the sixth in a series of 10 webinars that we're hosting focused on CAH finance and operations. You'll see the next 4 webinars listed on this slide, and you can find more information on the ORH website with the link I'm adding to the chat in a moment. Next. And with that, I'm pleased to introduce our speaker. Rob Bloom is a principal at Wintergreen, and prior to joining Wintergreen as a principal, Rob served as CFO for Carthage Area Hospital for over a decade. He previously held positions with the hospital as Administrator of Primary Care Services and Interim Chief Financial Officer. In addition to his role as CFO at Carthage, Rob also served concurrently as Chief Financial Officer at Claxton Hepburn Medical Center and Orleans Community Hospital, in addition to providing consultative services to several other hospitals in rural New York. Thank you so much for being here, Rob. We're excited to hear your expertise, and I will turn the floor over to you.
All right. Well, thank you very much, Sarah. I appreciate the introduction. So I will go ahead and jump right into, really hitting what continues to be a fairly large opportunity for hospitals, particularly in the rural space. And we've really broken this down into, 3 functional categories, defending revenue, collaboration, and cross-functionality, and revenue integrity and stability. So when we start to think about defending revenue, one of the things that is always a surprise to me when we go in to do a revenue cycle assessment or a strategic planning session at a rural hospital, oftentimes what we find is that hospitals don't even know where all of their third-party payer contracts are housed. And one of the things that we continue to find is that there's not a firm understanding of the terms and structure of those contracts. So what I mean by that is increasingly what you're seeing is the third-party payers put in these terms into the contract that either allow them to make changes to the contract based on some set of policies and procedures that they maintain on their website, but they get to change those really without any negotiation. And it's the hospital's responsibility to continuously monitor those changes. And the reason for this, of course, is it increases their opportunity to deny claims for failure to comply with policies. Oftentimes, we also see that senior leadership is really not engaged in negotiations from a multidisciplinary approach. So when we think about, how we want to approach our overall strategic plan, obviously our contracts with the third-party payers are a very, very important part of that process. And it really is not useful if we just have the CFO or potentially the billing manager or revenue cycle director trying to negotiate those contracts in a little bit of a vacuum. So I'm sure you've all heard my partner Jonathan talk from time to time in various settings about the need to break down the silos that exist within healthcare. This is another place where that has become increasingly important. And once we've, really started to dig in, one of the things that we find is we need to create a contract matrix so that we can identify a prioritization to renegotiation. And sometimes we might even be trying to request a renegotiation out of cycle if we find a contract that's really starting to hurt us for whatever reason, right? Whether we've had a new employer come into the market and we've got more exposure, or there's just something has fundamentally changed and the nature of the contract doesn't work for us well. So at the bottom of these we've summarized what are some common discoveries we've had based on various revenue cycle assessments. So the first one, failure to identify benefits based on our designation. This has become more and more common as managed care continues to expand within the market, particularly applicable to critical access hospitals and rural health clinics. The managed care companies are very good at trying to get hospitals to contractually give up the reimbursement methodology that they're entitled to. And that's one of the places that, we see a lot of money get left on the table because we're giving up those benefits through our own agreement to do so. The other thing is we don't address contract language that's very generic or non-specific, meaning we don't really know what it means. And the last thing we want to do is leave that open to interpretation. We found often that there's just failure to monitor and maintain the services that we're providing, right? So we start a new service, we bring on a new provider. We're not updating the payer websites with all of that information. And that can also become a challenge, of course, even from a referral standpoint, as places look to make sure that they're referring to the organization that has the services that a patient needs. Pharmacy and supplies are another place where oftentimes that's a carve out and additional payment that just gets missed in the process. And then also, and really in some of our provider-based clinics, so not necessarily rural health clinics, we often find that people essentially start billing out on a $1,500 and getting paid a physician fee schedule versus getting the technical component as well. So jumping a little bit deeper into the reimbursement strategy. So that has to be linked to the strategic plan. We have to take a multidisciplinary approach. We want to make sure everything that we're trying to do from a quality and clinical standpoint, we are aligning our efforts with incentives within the contract. And this is one of the places that I think is an often overlooked opportunity to reopen contracts out of cycle. So, when you approach that third-party payer and say, hey, we really need to renegotiate this contract, the conversation goes a whole lot better if you can bring to the table a reason that they would want to do so. Because, of course, to just say, we just need to get paid more, it might work some of the time, but it's much better to come to the table with, a plan for why it's going to be valuable to the insurance carrier to reopen that contract. Because, of course, what we're trying to say is we're taking better care of your membership. And again, as we kind of jump into what's out there routinely, we will see things like a failure to identify preventative services, and oftentimes we fail to market the no out-of-patient costs or no out-of-pocket costs for patients for those preventative services. We often find that when we look at our billing departments, they're not really evaluating payment variances, and quite often the reason for that is the don't know how the claim should have been paid according to the contract. because quite often the billers have never seen or been briefed on the contract. We see lack of participation, implementation, monitoring, and expertise with incentive and quality programs. And the shame there is that most of the time the hospitals are doing all of the things they need to do to get those incentives. They're just not, working through the hoops to make sure that they get the payment. And that brings us to the last one, which is lack of coordination across organizational silos, because oftentimes, we need to submit some sort of documentation-based information into the third-party payers because for whatever reason, they're really good at not being able to monitor the CPT codes. So sometimes it does take a little bit more effort to prove that we have in fact met all of those. And of course, it's much easier if you can spread that lift across the organization versus just trying to do it within the billing department. So denial management. This is an area that I think is probably the most underreported opportunity for a number of rural hospitals. And, we'll get into it just a little bit more here. But one of the reasons for that is a lot of hospitals actually don't have good optics around understanding what their denial rate is. So I've been to, a number of facilities who, when you look at what they're reporting, it appears that they have, benchmark or really close to benchmark denial rates. But when you kind of dig into some of the EOBs that are coming back from the third-party payers and start looking at the ways in which the claims were adjudicated versus the way the contract was structured, what you start to find is that oftentimes these denials were masked as contractual adjustments, just being adjudicated through the process of the claim. So whether it was, line items that were paid at zero that shouldn't have been, or other things like that, a lot of the denials are actually hiding in those contractual allowances. And there's a lot of reasons for that. So first of all, again, coming back to understanding revenue potential, our billers don't often know how the claim should have paid. And the payers are really good at convincing billers when they get on the phone that they did everything appropriately. They're really good at always having a reason why they did what they did. And most of the time, our staff tends to buy that argument instead of elevating it and really trying to push back on it. And of course, they continue to do this because they've learned it works. And the last piece there is sometimes there's just a lack of effort around it. For whatever reason, either we're understaffed as recruitment is hard in rural areas and we just can't get to it. Or, there's some reason people don't want to recognize the problem. So one of the things that we've seen happen time and time again, when we really start to interview folks and say, why aren't we, kind of jumping on these issues? When you start to talk to some of the, billing managers and even some of the staff, what you find is we've created KPIs that sometimes incentivize obfuscation of the challenges. And what I mean by that is we might have this focus on, net days in AR or trying to keep AR below a certain number of days. And sometimes what that causes our revenue cycle leadership to do is just adjust claims off. I mean, I've actually been in hospitals where there were revenue cycle leaders who saw one of their goals as getting their write-offs done versus getting the cash collected. And so we always have to be cognizant of those types of issues popping up on us. And then also we find that a large percentage of denials are just never resubmitted. It's actually typically north of 40%. So there's really a significant amount of money on the table here. I would say I've personally never been involved in a revenue cycle review where we didn't find, somewhere between, 3 and 7% of just what I'll call low-hanging fruit. And so we really need to make sure we're establishing robust denial management protocols so that we're not creating some of these perverse incentives, and we're really making sure we're trying to prioritize revenue maximization and cash collection over, managing some metric that is largely meaningless. And of course, as you take this out, going back to that concept of everything really needs to be linked to that strategic plan. When you start to try to do any sort of modeling of a change in your organization or expected changes in volumes, you're really not, taking that historical information and forecasting it into the future appropriately if we don't even understand what the proper revenue potential would have been, which can make fixing a struggling hospital that much harder because we just can't seem to, get our hands around, a solid fix to it. So, again, what we found is, we have to put a cross-functional team together to make sure that we are engaging the entire organization, and that's going to include a lot of your care team, as oftentimes they're the folks involved in this. Come up with an organized process to make sure that we have an environment of routine reporting of denials, identifying trends and root causes, making sure this is not, viewed by the members that are involved as a blame game, but a way to ensure survival of the facility. And then we have to, of course, implement solutions, maybe adjust policies and protocols to make sure that we're collecting those denials. And ideally, right, we want to be preventing future denials, and that reduces the work. Establish analytics. And again, as I said, oftentimes what we find what's reported is not actually an accurate picture. So we need to spend some time working on that. And time is of the essence here. We have to act quickly. Timeliness is a challenge. And the third-party payers are really good at trying to take advantage of that. And then finally, let's make sure we pause to celebrate the victories as we get them, because we want to make sure that our staff knows that their efforts are appreciated. So collaboration, this is something as we move forward and what's becoming a much more complex environment as a must. So, again, communication is going to be key here, and clinical leader education is as important as everything else that we're doing. So, if you stop and think about on the back end, what are we going to do if we failed to document something that a provider maybe provided to the patient, but, just didn't document? Well, we can't do too much after the fact. We can maybe, try and get them to do an amended note, but it's much better if we can build those prompts into their workflow. And we really have to be working with those clinical leaders to make sure that on the revenue cycle side of things, we understand kind of what their flow looks like so that we can help offer the benefit of our expertise without them feeling like, all we care about is revenue maximization. It's not the patient care, because of course we care about the patient care. We just understand that we need to get paid for what we do. And in order to do that, we need it all to be documented. Another thing that we found is a lot of providers just need a little bit of education. Like, if you do this, which oftentimes you either are doing or you just didn't know you needed to do, then we can get significantly more reimbursement. And once they know that, we find that most providers are pretty willing to do something to improve the overall financial health of the organization. And one of the other things that we've noticed here over time, as we've had turnover in a lot of the leadership roles in the clinical departments, is a lot of these newer clinical leaders, so nurse managers, things of that nature, they don't know the same things that manager who just retired, that might have been working in that job for the last 30 years, knew through the benefit of all of that on-the-job training. And so we need to make sure that we're educating that person, making sure that they know that fiscal viability is a part of their job, even though they're a clinical leader. And we need to arm them with the information to help us make sure that that's something that is happening on a timely basis. The next area that we often find there's significant opportunity is with regard to schedule utilization and effectiveness. So if you look across the rural book of business in the country, one of the things that you'll see is oftentimes productivity is a challenge, and so often that really tends to get thrown at our providers, but we don't always take a step back to try and understand what is preventing us from being efficient um, in our areas. So, the first step here is, of course, just map what's going on. Do a process map. Try and figure out what's out there, right? Look at the schedules. Do we have, every patient set at 30 minutes or 45 minutes, or do we actually have a template that's based on best practice, right? Are we going to say, 45 minutes for a new patient, 15 minutes for this set of circumstances, right? If it's a sore throat, it's a quick visit, we're gonna put that in there, and maybe there's something that's 30 minutes. But we need to make sure that we're setting those templates up for the schedule, so that we can maximize the number of patients that we can see. Because of course, one of the things that you'll find that it seems so incredibly simple. And I actually had a chief medical officer at a rural hospital state this the best that I think I've ever heard it stated. And he said, "We have plenty of capacity. What we lack is access." And what he meant by that is, as patients are calling to say, "Hey, can I get an appointment?" In that particular hospital, their schedules were set in such a way that there was no place for the receptionist to plug that patient in. And so once we went through and got a team together to figure out how to properly template that schedule, we were able to largely solve a lot of that issue and increase their productivity. The other place we have to look is, what are the workflows? Do we have the right resources in there? And again, you're going to say this maybe sounds more operations and less revenue cycle, but it really does have to be cross-functional, because of course we need to make sure that within the various types of visits, we're leaving space for what the provider is really going to need to do to maximize reimbursement. The next area that we continue to see opportunity is that we find hospitals aren't really addressing patient-driven inefficiencies, otherwise known as no-shows and cancellations. So what are we doing to try and understand why that's happening? What are we doing to try and help those patients better schedule, or maybe it's as simple as we're not doing reminder calls, because sometimes people just need those. And oftentimes it's not because people just don't want to do it. They just get busy in their day, and that's the thing that they don't get to. So we need to look at, well, what is that costing us, and what should we be putting into it as a way of recovering that revenue? So these are all areas that we see ongoing opportunity. And the last, of course, establish benchmarks. So normally when we take a look at particularly some of our productivity benchmarks, we find that it's really pretty dated, sometimes in excess of 30 days after the time has passed. And it's really, really hard to address issues when the information we're using is so old. So really one of the goals needs to be to find ways of getting some form of near real-time monitoring of performance, so that we can make corrective action before another entire month has gone by, and we see nothing really changed, because of course that just extends the problem well into the future. So duplication and redundancy. This one kind of cuts two ways when we look at the revenue cycle. And again, this comes down to needing to do some form of a process map, to include software to understand what path does a patient encounter take from the time the patient walks in the door until we've been finally paid for that claim. And so one of the steps is, perform a software analysis. I can't count the number of times that I have seen hospitals paying for, duplicative services, perhaps whether it's in just, two slightly different care settings, or sometimes, one that, somebody purchased and never really got fully implemented, and then somebody new came in and implemented something else, but somehow nobody caught the fact that the hospital was paying for two, eligibility services, one being used, one perhaps not being used, or maybe they're just being used in different areas, but at an increased cost versus an enterprise-wide solution. So we really need to perform that software analysis. And, again, this takes a multi-disciplinary approach, because we might need to pull in, the accounting side of the house to find out, hey, what are we seeing in AP? Do we know what's in there? Then the other thing that nearly every vendor out there will offer to do is an optimization assessment. And really what that is just, them sending a team out to say, hey, have you installed this software properly? Do you understand all of its capabilities, and are you taking advantage of those things? How have you used some of the reporting capabilities within it to monitor how your organization is performing? And oftentimes we find that, you might have a particular software that everybody at the hospital just really can't stand. It's the worst thing in the world. And then when we bring those vendors in to do an optimization assessment, oftentimes what we find is people just really didn't know how to use the software, so it was frustrating to them. And some of the things that they had identified as needs, the software actually had a solution for. We've also seen some, failed implementations where, for whatever reason, we just didn't install the software the way the vendor had designed it to work. Maybe we made a change to fit the way we had always done it historically, but sometimes that will render the software incapable of doing what it needs to do. And so then we also find that all of these issues can lead to duplication of effort. And so what we're talking about there is, you might have somebody in the clinic who's, trying to resolve some issue, and they're monitoring a certain problem. And then you might also find there's somebody, somewhere in the revenue cycle or even in an accounting department trying to track and monitor the same things. And because, we've evolved into this, siloed work approach in many facilities, we don't ever get together and compare notes, realize that we don't need two people doing the same thing, but never sharing the information with each other, sometimes never sharing it on up in the organizational chain of command. And so, that really means we're paying for a lot of additional staff hours and effort that we don't need to be paying for. And, that's always an opportunity for us to reduce costs, and will also help, as we work through that, to establish those routine monitoring processes that we need to have in place. So charge reconciliation processes, this is another area that, sort of goes hand in glove with, item master maintenance. But what we're hoping to do here is ensure that we've got timely and accurate charge capture. And it's amazing to me how often we see that nothing has been done in a number of years, or maybe nothing's done on a routine basis to make sure that we're capturing all of the information that we need to. As we get better at this, we can seek ways to, automate certain things, whether that's through order entry or, different approaches working with our informatics teams. But the goal here is to reduce that charge lag time, try to get to that best practice of 48 hours so that we're not holding our claims a significant amount of time before we get them out the door. But, really what we're also trying to do is make sure we're taking credit for everything that we do. So oftentimes we'll see, there might be, a physician that, maybe performs some sort of, bedside ultrasound, and we just failed to ever capture that charge. And that might be a separately or additionally reimbursed procedure that we just performed on that patient, but we're not taking credit for it. We did the work, but we're not taking credit for it. And the only way for us to do this is really to work, again, with those clinical leaders, and it's reviewing the chart, and it's getting out there and just talking to people and looking around to say, hey, what do you do on a routine basis? Otherwise, we just don't tend to get into enough detail to find these issues. And there's been an ongoing challenge sometimes in getting some of our department leaders to get involved here, particularly on the clinical side. Sometimes, we start talking in revenue cycle jargon, their brains just kind of turn off. They don't want to hear that. They want to focus on patient care. So, we really need to be mindful of how we're trying to approach this and help them understand what our end goal is to make sure that, we're giving their department credit for all of the effort that it's putting into taking care of our patients. And so as part of this, we have to do a reconciliation process looking for these missing charges that has to include the department. Because again, on the backside, we're just not in a position to know everything. And then that also then means that we have to maintain and review an up-to-date charge master with those departments and get their input. And part of getting their input is going to mean we have to educate them. We have to explain to them sometimes what changed. We have to do everything we can to, get rid of that notion that we sometimes come across that, well, I'm not a coder. I don't need to know that. That's somebody else's job. Because of course, well, they do need to know what types of codes are going to be used in their department so that they can educate their staff and help to then turn around and educate us on the back end to make sure that we're maximizing every possible dollar for the work that we are doing. Then that leads us to establishing routine monitoring of responsibility on the charge lag report. So, this is one of those things that, oftentimes there's a little bit of revenue cycle involvement in. The accounting department might look at it every month and get frustrated with the amount of charges that are getting entered, outside the period when they should have been captured. But we really need to elevate that. That needs to be something that we're reporting out to senior leadership and arguably should be part of a board dashboard to make sure that, we have expectations and responsibility established around timeliness. And the other thing that charge lag report is good place where we have some sort of a broken or less than optimal process. Because of course, oftentimes the reason things are showing up there is something's broken. Why is it taking some level of manual effort to generate that charge? Those are those areas that then connect back again sometimes to some of our, understanding that software matrix. Do we have an interface that's not working? One of the things that's always amazing in hospitals is, the ingenuity of our employees to find ways to get things done. But it often means that, there's been an inefficiency in the process created as they've just worked to make sure that, hey, I am getting the charge done. Whatever I had as a tool, it stopped working, but I figured something out. So we have to, constantly monitor that. And then again, coming back, we have to keep re-educating them and engage them in, okay, how are we going to fix this? And that's where, we might have to bring in that informatics team, the IT folks, to help us fix that. And sometimes, we just need to make them cheat sheets. We need, we find just strange things out there. Maybe there's something in order entry that's challenging for them. Like, they have a drop-down menu that doesn't show them what we think it ought to. And there might be some reason, whether it's the number of characters that the software vendor has allowed to put in there or what have you, that means, they might accidentally click, CT without contrast when what they really did was CT with and without contrast. But, through some truncated abbreviation, they didn't really know what they chose. And so that's one of those challenges that we see. And it's something that's fairly easy to pick up on through a reconciliation process. So revenue cycle efficiency. This really isn't just about some KPI dashboard that we're monitoring. Really, what we're wanting to do here is make sure that outside of that, what is our staff doing? Are they working as efficiently as they possibly can? So, there's an old saying in healthcare, if you want something done, give it to a busy person. And, what that often leads to is a lot of knowledge and a lot of inefficiency being focused on one person. That can also, create over reliance on that individual, and sometimes can cause us some turnover problems. And it's oftentimes not that other members of the team aren't willing to, it's just, well, they were doing it and it seemed like it was getting taken care of. So, nothing more was done about it. But through that process of, trying to map out, what are our staff doing? Can they tell us what happens in a day? We will find opportunities to improve things. We'll find opportunities to automate. So, one of my favorite things that I like to do is, walk into, say, a clinical setting, whether that's, main hospital registration or in an outlying clinic, and just watch what happens. And I would say, it's more often than not that what I will observe is, a registration clerk take a set of papers, hand it to a patient. The patient fills all that out. Then the registration clerk types all of that information into the computer, and maybe they scan the papers in as well. And then they turn around and they throw them in the garbage. And so, you start to have those conversations, and what you find out is some of that was just duplicative information that maybe they needed to collect on the first visit, but they're continuing to hand out at every visit, which, frustrates the patient. They're filling that same paperwork out again. It creates an inefficiency on the front end, which, that might mean that because they're busy doing all of that, they're not running their eligibility check to make sure that all of the insurance information is in there properly, right? Maybe that means they are not getting to those reminder calls. And then, of course, we're, throwing away paper, which, while it's not terribly expensive, certainly isn't free either. And so, then you dig a little bit further and you find out, a lot of this information could have been obtained ahead of time through the, functionality within the EMR that's being used, or that, they could have simply had the patient enter that right in through one of the, patient kiosks. So, that's an area where, we're trying to look holistically at what our employees are doing and make sure that, we are automating as much as we possibly can and spreading the burden across the appropriate people. So establish analytics. Again, key performance indicators. This is a conversation. There's no one size fits all. There are variances in organizational capabilities. There are variances within EMR systems. So there's not a set. It's a conversation about, okay, what do we see as our issues? And so what KPIs do we need to monitor to improve our own challenge? Oftentimes we'll go in and we'll find out that, staff don't really have any performance expectations that they can, communicate back to us that would lead us to believe that, those conversations are happening and the staff really knows what's important on a daily, weekly, monthly basis. So we need to, set those indicators. We have to communicate them to the staff. We have to communicate them up through the organization so that senior leadership knows what we find is a challenge for us and what we need to monitor. And then we have to, set those expectations with the staff. We're not going to be perfect tomorrow, but we should be seeing incremental progress as we move through time. And then again, I'll return to, we have to beware creating those perverse incentives, and again, that's that thing that might cause our staff to start managing KPIs instead of managing cash collection and revenue maximization. Every time that we see that scenario happen, usually what you have is an environment where there's just a lack of openness and trust. And, we have to really dig in and address those things, whether that's, senior leadership just saying, oh, there's a problem, you need to solve it and solve it right now. So guess what? It gets solved. The KPI says so, right? Unfortunately, it's just not as simple as that. And that brings us finally to monitoring performance, right? We have to drive that improvement culture. And unfortunately, that's just one of the things that if we can't get, an open culture where everyone is wanting to improve, everybody is wanting to, raise up challenges so that they can get solved, it's very difficult to move this forward. And as reimbursement gets even more complex, and then we start thinking about what does it look like if we start to get into shared risk arrangements, that becomes a bigger challenge for us, right? If we can't do it at the level of complexity that we have today. So we have to, celebrate those wins as they, come along. If we've gone from, a denial rate of 12% to 10.5, we want to celebrate that, right? Because there's a lot of jobs and additional potential to reinvest into the provision of care in our community, and that 1.5% win, and we keep making progress. We have to make sure that the staff feels that, right? They're not afraid to identify challenges. They know what their goals are. And when we see failed processes, we're making those adjustments on a timely basis. And we're trying to look at the challenge holistically, right? And I think the biggest thing is make changes. I can't tell you the number of times when you ask, why do we do it that way? The answer is, well, that's just how we've always done it. We should be constantly making changes, constantly trying to improve, and actually celebrating the failures, right? Because that's how we improve. Not every change we make is going to have the outcome that we anticipate. We see, in our quality departments, we're trying to get the hospitals to adapt, the PDSA or whatever acronym you would like to choose. But we're trying to get people to say, hey, let's make a change, let's monitor it. And when it doesn't work, let's make an adjustment so that we can try to improve the organization. So with that, I will turn it back over to Sarah for any questions.
Thank you so much. Really great presentation, Rob. Appreciate it. We do have a few questions here. The first one is, do you have any recommendations for charging for patients boarding in EDs at CAHs? And this is in reference to patients who are awaiting an inpatient bed.
So I guess there's a number of answers depending on the situation. And of course, I'll caveat everything with, I don't know Oregon specific rules that the state might have in place that, might have a larger burden than the federal government. And also, do we know, I guess the first question is this a challenge that we're seeing because we have a full census, right? We just don't have a bed available.
I assume, yes, the person who asked the question said yes.
So then I do have the answer. So you can get authorization from the Department of Health to exceed your census, right? No different than we had COVID waivers during COVID where we didn't have to get permission. The only change is we have to get permission, right? So remember, the place the patient is laying does not determine whether or not they are an inpatient, right? It's our physician's order that is going to drive that status. So what we would need to do in this particular case is, work with the Department of Health, find out, who the contacts are to authorize that, right? Do a small documentation, whether that's in the nursing supervisor's report, et cetera. Hey, here's what's going on. Here's why we're doing it, or why we're doing it. And hopefully, get that authorization to exceed that bed count. So this is an issue that, the at Carthage, the hospital where I was the CFO, we had routinely, particularly because we're very close to a large military base that doesn't have a hospital. And so we had to, kind of go through this fairly early on because, when everybody was at the base, we would sometimes, have ER volumes that would be in excess of 15,000 a year, which then meant a little bit more inpatient demand than when everybody's deployed. So yes, you can seek, authorization from the DOH on that. I think you're muted, Sarah.
Thank you for that. I appreciate it. Um, Thank you for your response. And the person who asked the question said thank you as well. Next question is, what kind of success have you seen in terms of increases in revenue when applying the strategies you discussed today? Any kind of, range of revenue increase percentages that you can share or any success stories?
Sure. So I will say the range is a little bit easier to answer. The success tends to depend on the person's willingness to make changes. So I would say as a range, I've seen everything from, I've never seen anything below 3% to as high as 25%, depending on what the challenges were at the facility. Now, in terms of success, that's really driven by culture, right? And the willingness to change. And so what seems to make the difference there is, first of all, can we get the billing manager to be open and honest with everyone, right? And sometimes that's the challenge. And I don't want to say the billing manager is the challenge because sometimes it's the CEO or CFO who just refuse to accept answers from the billing manager, their staff, revenue cycle director, whomever's involved. Sometimes I find executives just want the problem solved and solve it tomorrow. It doesn't work that way. What we find is, when you're digging into revenue cycle, the challenges, can be in a number of areas, right? So we find that, there are claims going out on the wrong bill type. We find that something is wrong within the EMR and there's an improper taxonomy code going on, right? We find oftentimes that, for a hospital that might have converted statuses or changed recently, there's a problem on the payer's end with the setup. So then you get these situations where, say they're trying to get an authorization for a swing bed and, maybe the payer is having the, staff on the front end get it authorized under an old soul community number or something versus the appropriate critical access number. You really have to dig through where is the problem, right? Is it a process issue? Is it a software setup issue? Is something going wrong in our clearinghouse, right? Do we have some interface problems? And finally, did the third-party payers build our contract right on their end? Sometimes they make mistakes, sometimes they're intentional. But what we do find is the biggest indicator of how successful it will be on the back end is what's that true denial rate. So what we find is once the third-party payers figure out you're an easy target, they just keep coming after you. That's why, I try to push everybody to have a stance of we're going to fight for every dollar, even if we take a step back and it seems like, well, why would we put $200 worth of effort into getting that $50 worth of additional revenue? And my answer is simple, because if I don't, it'll cost $500,000 because they're going to keep scraping it off the top until they bleed us dry. They have to know that we're going to fight for everything that we're entitled to.
Great. Thank you so much for that. Last question that I have, and please do feel free to put your questions in the chat or raise your hand and I can unmute you. But the last question I have for now is, what are some of the key KPIs related to the revenue cycle that you've seen defined at CAUSE? I know you mentioned KPIs, but do you have any examples of some that you found to be particularly helpful in making improvements in revenue cycle?
Sure. Well, let me start out with the one that I singly hate the worst, which is net days in AR. I could care less what that number is because if we all take a step back, we're a journal entry away from any answer that anybody wants. So let's just take that one off the table. Let's never set that as any kind of a goal. But really the ones that I like to look at are based around, contract conversion rates, right? So if I have a a Medicaid managed care contract, right? I know what I should get paid on a particular set of claims. We need to know what that is. I often like to start simple, so for critical access hospitals, rural health clinics, let's start with anybody who's supposed to be paying us on a really simple rate, right? That's either a per diem, percent of charges, or an all-inclusive rate. Because it's amazing to me how often the math doesn't work and nobody questions it, right? And again, what you start to find is when you look at that EOB, you might find an EOB that has, something that was, a zero pay. And when you look at the reason, it'll say, it was inclusive of the APC. What's not applicable in this setting? And so, we want to make sure that, we start with the simple stuff, right? Those claims that are easy to calculate, we get them. But then we set up, tools for our billers to do some of the more complex things, teach them how to do that contract conversion. And we really look at what's the yield, right? So is this contract yielding what it should be? That's really the one I like to focus on, because at the end of the day, it all comes back to cash. And that's where I like to focus.
Awesome. Thank you so much for that. And I have not seen any other questions come into the chat. So if you could advance to the next slide, please. There we go. And I do want to thank you again, Rob, for a really great session. And note, before you leave today, there's a survey that's going to pop up when you exit the webinar. So if you can take a moment to complete that, it'll help us continue to bring you programs like this one. And we'll have the opportunity to improve them in the future and for you to earn continuing education credits as well. I'd like to take a moment to share just one announcement from the Office of Rural Health with you. The next webinar in this series is the Post-Acute Care Lever Hospital Swing Beds, which will be held on July 13th at noon. Registration is at the link that I put in the chat at the beginning of the webinar. I'll put it in the chat again in a moment after I'm done talking. And with that, I will close out. Thank Rob again and appreciate you all being here with us.